Hello, everybody. My name is Steve Edelman, and welcome to the Spotlights, the virtual Spotlight series. I'll tell you a little bit about what we're going to do tonight, but since my good friend and colleague came on, Tricia Santos, let me do a quick intro. She will be speaking first. Tricia is an endocrinologist. I met her when she was like this big at UCSD as a student, and now she did her fellowship there and has been on faculty and doing a tremendous job educating not only medical students, but residents, and also what we call endocrine fellows, the future diabetes doctors of the future. So our Spotlight series, we usually have in person. We usually have 150 people. It's right here in San Diego, and this is our second Spotlight series. The first one I did with Jeremy Pettis on type 1 diabetes, and tonight it's going to be type 2 night. We talk about all the advances in type 1, continuous glucose monitors, hybrid closed loop, all this fancy stuff. But believe it or not, what Tricia and myself are going to show you tonight, that there are some truly exciting developments in type 2 diabetes. And I also have some announcements at the end of my presentation before we open it up to the virtual health fair. Dr. Santos is going to really tell you about how the therapy of type 2 diabetes has changed tremendously. Can't say that enough. And then I'm going to follow up with some real life cases from the university and the VA hospital. So I want to thank everyone at TCOID for making this virtual program possible. And it's going to be online later on. So in case you miss it or your friend wants to see it, it'll be there too. So Tricia, why don't you take it from here?
All right. Can everybody hear me? Can you hear me okay, Steve?
Yes, I can.
Okay. I'm going to share my screen so you can all see my slides here. All right. So I'm really excited about tonight because we do this type 2 night every summer in the middle of July. And usually we're in, a small auditorium, like Steve said, with maybe 100, 150 people. And it's pretty much limited to people who are in San Diego or who are near San Diego that come. And I've just been scanning through the chat box as we've been starting here, and I'm seeing people from Detroit and Albuquerque and North Carolina and Canada and all over the United States. So I think this is, definitely one of the silver linings of the pandemic, that we can all kind of come together even internationally and get educated, and we can reach so many more people. So very exciting news. So today, like Steve said, we're going to talk about kind of the new way from a doctor's perspective I'm going to give you that we think about treating type 2 diabetes now. And what I'll say is for many, many years, back in about 100 years ago, insulin was discovered. So that was the oldest medicine that we had for type 2 diabetes. And then we had, these are going to be some big names here for you, but sulfonylureas, biguanides, which is metformin, came along many years ago. And then really in the last 20 years, we've just had this kind of explosion of medications that are available for type 2 diabetes. And you would think that would have made things a lot easier for doctors and for patients to have all of these options available. But what happened is doctors kind of, it was a little bit overwhelming to have all these choices. And the guidelines were kind of telling us, well, metformin's the best first one to use, and after that, you can kind of use any of these that you want. And that's how we practiced for many, many years, until a couple of years ago, and very recently, when the guidelines have become much more clear, because some of the newer medicines have some benefits that are coming out that we didn't know about. So now I'm going to kind of go through step by step how we think as a doctor how to kind of approach type 2 diabetes from the medication perspective. So step one, of course, is lifestyle modification. And I'm only mentioning this because I don't want you to think we're skipping over it. Lifestyle changes in type 2 diabetes go a long, long way. And while we could spend kind of 8 hours or longer talking about all the different ways to make lifestyle changes, what I'll say to you is what I usually say to my patients, which is, when you think about making lifestyle changes and how they're going to affect your diabetes, it doesn't have to be this giant change in your life. So I would say start small with goals that you cannot fail at. So if your exercise goal is to walk to the end of the block, to the end of your street every single day, then start with that, because you know you're not going to fail and it's something you can achieve. or if you can, cut out regular soda, or if you can eat, instead of a whole bag of potato chips, a half a bag of potato chips. Start with small little changes and you'll be surprised how much of a difference that makes. So definitely lifestyle modification is should go across the board. You should always be thinking about lifestyle. And step 2 is very, very clear. So you can talk to all the big different societies that us doctors listen to, and they will all say metformin, metformin, metformin. I kind of think of it like when you're talking about real estate and they say location, location, location is kind of the most important thing. You should think metformin the same way about type 2 diabetes. So metformin is by far and away, we know it's the best medicine for type 2 diabetes. Now, I do have a lot of patients that come to me and say, I don't want to be on metformin because I know it's bad for my kidneys. And that is a huge myth. So metformin is actually not dangerous for your kidneys. And it turns out that if metformin is helping your diabetes so well, that's going to protect your kidneys by having lower blood sugars. So everybody with type 2 essentially should be on metformin. And there's only 2 main reasons. There may be some other small things here and there, but the 2 main reasons why you may not be on metformin is if you have severe kidney disease. If you have kind of progressive kidney disease, the metformin does not damage your kidneys, but it stops being cleared by your kidneys. So the metformin can kind of build up in your body. And then it can just become too much of a dose for you. So if your kidneys aren't working that well, that may be one reason not to be on metformin. And then for those people who have had severe GI symptoms like stomach upset, diarrhea, those sorts of things that really can't tolerate metformin, then that's a good reason not to be on it anymore. I would say if you've had those issues, you definitely do want to try kind of the extended release metformin, or even half of the dose of metformin. Sometimes people tolerate that a little bit better, and it's worth it to just be on even a smidgen of metformin. So the only 2 reasons, I have kind of a sad kidney here and a sad gut here. These are really the only 2 reasons that you should not be on metformin. But remember, metformin does not damage your kidneys. Okay. So that's very clear. Everybody kind of follows these guidelines. All the doctors know. You talk about lifestyle modification. You talk about metformin as the first medication that we start. But the big question, I think, for doctors and for patients is, what do you do after metformin? And that's where things get a lot more confusing, I think, both for doctors and for patients. So step 3 is choose another medication, which is kind of a generic step here. So we're going to spend kind of the majority of the time tonight talking about what medications are available after metformin and how do you decide which one is best for you. And I think it's really important to pay attention to this because many doctors even don't understand kind of how to choose between them. So this is something that you can really advocate for yourself. So it really boils down to kind of 6 different types of medications, and I've kind of classified them as the older meds and the newer meds. So we're going to start with the older meds first. The oldest medicine that we have for the treatment of type 2 diabetes is insulin. And many people think that insulin is reserved for kind of the end of the road, when you're at the end with your diabetes and none of the other medicines have worked for you. And many people feel like they're kind of a failure if they have to go on insulin, or they feel like they just, blew it with their diabetes and that's why someone's starting insulin. And that's actually not true. So our guidelines from the American Diabetes Association tell us that many people need insulin right after metformin. So insulin is not something to be ashamed of, or it doesn't signify that you're at the end of the road or you failed with your diabetes. It just may mean that your pancreas isn't working as well and you need to support it with a little bit of insulin. Oftentimes insulin's the best choice if your A1C gets up in the kind of 11, 12, 13, 14. I even have seen some patients with A1Cs of 18. So sometimes when your A1C gets up that high, insulin is the only thing that will kind of bring it down quickly, and then you may be able to use some other medicines. So insulin, even though it's an older medicine, is still a good one. Then we have this group of medicines, the sulfonylureas, which I think many people are familiar with, glipizide, glyburide. The meglitinides I have down here because they work similarly to the sulfonylureas. This is a pill that helps your body secrete insulin. It can cause some low blood sugars. And then we have the TZDs, which are also once-a-day pills that make your body more sensitive to insulin. So these are all our oldest medicines. I would say as a group, one of their strongest points is that they're nice and strong. They can bring the A1C down quite a bit. So it's still a great group of medicines to use. Now, we'll contrast that, and we're going to spend a lot of time tonight talking about the newer meds. So we kind of have three different groups of the newer meds too. We have GLP-1 receptor agonists. This is going to start to sound like a mouthful. But GLP-1 receptor agonists, or we'll just call them tonight GLP-1s. There's a whole long list of them here. SGLT-2 inhibitors, which is another mouthful, or SGLT2s we'll call them, and DPP-4 inhibitors, or DPP-4s we'll call them. These are all newer medications that have been around in the last 10 to 15, well, even sooner than that, probably in the last 5 to 15 years or so. But they're definitely kind of the newer medications for diabetes, and we're using them a lot more and more now, and I'll talk about why that is. So how do you know which one out of all these, the group of older medications and the group of newer medications, which one is right for you? And I would say it depends. So, we have kind of the older fast food fried chicken here, Kentucky Fried Chicken, and we have the newer Chick-fil-A, which is very popular now, or Popeyes in some area of the country. And really, it depends, right? So some people still like the good old KFC for a lot of reasons, and some people like the newer, fancier Chick-fil-A. So it depends on what medical problems you have, what your goals are, with your diabetes, and that's what we're going to talk about. So a lot of our choices now, before we kind of used to have these blinders on and say, we're only looking at your diabetes and that's all we care about when we're picking a medication for you. And it's not just about diabetes anymore. So nowadays we think about other things besides diabetes when we're trying to pick, because we have so many medications to choose from. We can think a lot more about the side effects, about the positive effects of some of these medications, in addition to how they're going to work for your diabetes. So let's get started. The first question that us doctors ask ourselves when we're trying to figure out which medication should you use in addition to metformin is, do you have heart disease? So some people may call this cardiovascular disease, or you may not think you have heart disease, but if you've had a heart attack before or a stroke, then that would be an example of cardiovascular disease or heart disease. So it turns out that two of our newest classes of medications, the GLP-1s over here and the SGLT2s, both reduce your risk of heart disease, which is pretty amazing because this is all independent of everything they do for your diabetes. They'll actually decrease your risk of heart disease as well. So these are examples of the GLP-1 medications. The majority of them, and all of them up until very recently, are injectable medications. So some of them listed here are daily injections that you give once or twice a day. Some of them are actually weekly injections. So I think the second people hear about injections, they get kind of nervous and they say, well, is that insulin? This is not insulin. And just because it's an injection medication, again, it doesn't mean that you failed your diabetes and you're at the end of the road. This is one of our best medications to use as the second medication for patients with diabetes. So with type 2 diabetes. And some of those injections are only once a week. So can you imagine just being able to take your medication, once a day, once a week on Tuesdays or whatever day, you like. Very recently, we have an oral version of this, Ribelsis, which is our first pill GLP-1 that's available. So now we have kind of all of these different ones available. So how do these work? GLP-1, it turns out, is a hormone that everybody makes. Whether you have diabetes or not, you make this hormone in your gut called GLP-1. And whenever food gets down here, this hormone is released. And it does a lot of good things for people with diabetes. So the first thing it does is it makes your pancreas secrete more insulin so that you can bring that blood sugar down. It also decreases the amount of sugar made by the liver. Now, you may not think this is important, but how many of you go to bed with a blood sugar that you're happy with, that's in a good range, and then you wake up and it's high and you can't figure out why, because you didn't do anything, you didn't snack overnight. The reason that happens is because your liver actually makes sugar while you're fasting. So this hormone will decrease your liver. It kind of calms it down a little bit so it doesn't make so much sugar. It also slows food emptying from the stomach, and it works in your brain and makes you feel more full. So this medication has a lot of good effects, and the medication GLP-1 works just like the GLP-1 that we make in our body. So it's kind of giving you that extra boost of GLP-1. Now, when we're asking ourselves, okay, does the patient have heart disease? We also want to know, do you have kidney disease? Because like I said, the GLP-1s and SGLT-2s can help your heart. Both of them help your heart. But the SGLT-2 inhibitors is another class of medications. It's the newest class that we have. And not only does it help your heart, but it actually helps your kidneys as well. So this class of medication has been shown to decrease the progression of diabetic kidney disease, which is pretty exciting. The kidney doctors are so excited about this. They're using it, almost as much as many of them are using it, even more frequently than some of the diabetic doctors sometimes. So sometimes I'll even see a patient back, and since the last time I've seen them, their kidney doctor has started this medication as well, because they're so excited with how protective it is of the kidneys. All of these medications are very difficult to say. They're kind of a mouthful: dapagliflozin, canagliflozin, empagliflozin, erdagliflozin. But this is the list of them here by their brand names as well. Now, the way these medications work is they make you pee out your glucose. That's kind of the most simple way to think about it. So here's a little kidney here. The kidney normally filters all of your blood so it can try and take out your waste. And normally your kidneys reabsorb all that glucose so your body can use the sugar for energy. But with SGLT-2 inhibitors, they block that reabsorption, so they flush out all the glucose into the bladder, and then you just pee it out. And on average, this is about the amount of sugar you would pee out in one day. Pretty cool. Okay, so just to summarize there, if you have heart disease, or if you have heart disease, then we think about using either the GLP-1 or the SGLT-2s. If you have kidney disease, then we think about using the SGLT-2s. So that's kind of how we pick right off the bat which medication to use after metformin. After we think about heart and kidney disease, then we ask ourselves, do you need to lose weight? And if the answer is yes, it turns out we have medications that help your diabetes and also cause weight loss. And it's the same two medications that we just talked about. It's the GLP-1 receptor agonist. I've had this little picture here of the gut to remind you about that gut hormone. And those SGLT-2 inhibitors that make you pee out your glucose. So both of those classes cause weight loss. They don't, we're not talking about helping you lose 110 pounds. So these medications don't cause that much weight loss. It's a moderate amount of weight loss, but I can tell you just from personal experience, some of my patients, just getting that little jump start of losing 10 pounds or 15 pounds really has put them on track to kind of keep losing weight and stay motivated. And some people have lost much, much more weight than that. The other thing to remember is when we're talking about weight loss, you do not need to lose a significant amount of weight to have really drastic positive effects on many of your medical problems. So even losing just 5% of your body weight, which would be 10 pounds if you were 200 pounds, means that you can have reductions in blood pressure, You can improve your diabetes, you can improve your cholesterol, you can improve things like sleep apnea, back pain, all sorts of different medical problems by even losing just a tiny bit of weight. So even a small amount of weight with weight loss with these medications can be really, really beneficial. Okay, after those questions, so first we say, do you have any history of heart disease or kidney disease? And then, do you need to lose weight? We also think about hypoglycemia. So everyone is at risk for hypoglycemia if they're on certain medications, but some people can have more severe effects from a severe hypoglycemic episode, for example. So in patients who are having really frequent hypoglycemia, it can be more dangerous. In an elderly patient who may fall and break a hip if they have hypoglycemia, that's considered very high risk. So in patients where we're really worried about hypoglycemia with blood sugars less than 70, we want to avoid medications that can cause low blood sugars. So the only two medications of the six of them, the six kind of groups of medicines that we talked about that can cause low blood sugars is insulin, and I'll take off this cross here so you can read it a little bit better, but insulin can cause low blood sugars, and then the sulfonylureas and the meglitinides like Prandial and Starlix can also cause low blood sugars. The other medications that we talked about don't cause low blood sugars all by themselves. So certainly if you're on insulin and then you add a GLP-1 medicine or an SGLT-2, even though they don't cause low blood sugars, all of a sudden you may have some low blood sugars because you're adding on to insulin or you're adding on to a sulfonylurea. But in people who are not on insulin or sulfonylureas, you really should not be having low blood sugars. So these are the two classes to kind of avoid if that's a high risk for you. Okay, sometimes I've been talking kind of a lot about the newer medicines. So the SGLT-2 inhibitors that make you pee out your sugar and the GLP-1 that's like that gut hormone have many benefits such as weight loss and protecting the heart and kidneys. But sometimes older medicines are better. And there's a lot of reasons for this. So one of them is cost. And I think a lot of people feel like this picture over here where it seems like these pill bottles are just filled with your cash because you're just dumping so much money into co-pays and donut holes and trying to be able to afford your medications. And those newer medicines that we were talking about cost more. So two really good options that I use a lot in my patients who cannot afford a lot of these medications are sulfonylureas and TZDs. These are two medicines after metformin that you can use that are very, very strong. So they work well to bring your A1C down, and they're much more affordable than some of the newer options. So if cost is the biggest issue for you, it's a bigger issue than heart disease, it's a bigger issue than weight, I would definitely say look into the sulfonylureas and TZDs. And it's important to communicate with your doctor about this because if they prescribe you a medication that's, you know, $150 a month for a copay or $400 a month for a copay, you're not going to be able to afford it and you're not going to take it. And it does nobody any good. So there's no point in prescribing it. So this is really needs to be kind of an open conversation with your doctor or your healthcare provider about this. The TCOYD website has many great resources, including resources on cost-effective care. So I urge you to check out this link here. Maybe we can even put it in the chat box at some point at the end tonight. But if you're looking for kind of cost-effective care, this is a great place to look as well. I do want to talk about the fact that recently we've had, in the last few years, we've had more and more combination medications come out that kind of just can make your life easier. So the latest one to get FDA approved is Tricia, and this is the first pill that has 3 diabetes medicines in one pill, which is pretty amazing. So it has an SGLT-2 inhibitor right here in empagliflozin. This is the one that makes you pee out your sugars. A DPP-4 inhibitor, and metformin. And it's pretty amazing that you can get kind of the combined effects of all 3 medicines in just one pill. There's also several combination pills available with 2 medicines in 1 pill. And I would say, you know, I think it's very convenient to not have to take multiple pills, because some of you probably have not just your diabetes medicines, but blood pressure and cholesterol and all sorts of medicines that you're taking. But again, this goes back to affordability. If it's cheaper for you to take 3 separate pills, it works well, just as well to take the 3 separate pills as well. The other combination that I wanted to make sure you're aware of is something called a fixed ratio combination of GLP-1 and basal insulin. So GLP-1s are those medicines that cause weight loss, that protect your heart, and most of them are injectables. So if you want to try a GLP-1 injectable and you're on basal insulin, so a once-a-day insulin, you can actually take the once-a-day GLP-1 injectable and the basal insulin together in 1 injection. They come in 1 pen. There's 2 of them available, Soliqua, which is a combination of glargine or Lantus, plus lixisenatide, which is the GLP-1, or Zoltify, which is a combination of insulin degludec or Tresiba and liraglutide, so which is another GLP-1. So it's kind of nice to be able to take 2 medicines in 1 injection once a day. So that's another benefit. Okay, so I think the big take home and probably the biggest change that we've seen in the last year or 2 in our recommendations for patients with type 2 diabetes is that it's not just pick one of any of these 6 types of medicines after metformin. What we're seeing now is much of the time, the preferred medicines after metformin are the GLP-1 receptor agonists, which are those gut hormone ones, and the SGLT-2 inhibitors that make you pee out your glucose. So those are the first choice if you have heart disease, if you have diabetic kidney disease, if you're overweight, or if you're trying to avoid hypoglycemia. If you're trying to avoid hypoglycemia, you can actually also take DPP-4 inhibitors, which is a once-a-day pill that's very well tolerated. Most people don't have any side effects from it. Or the TZD, which is one of the older medicines that we talked about. Both of those are other options that don't cause hypoglycemia. But you can see that the GLP-1s and the SGLT-2s are really rising to the top in terms of being our first choice much of the time, unless cost is an issue. But again, you kind of have to think about all of these things. So I'll end by saying, you know, even though we have all of these different choices, every single patient is different. And there isn't kind of a single recipe that will, or prescription that will fit every patient with type 2. So you are different than everyone else who's listening tonight, and it's important for you to talk to your healthcare provider about the other, you know, things that other medical problems that you have, like heart disease, kidney disease, whether losing weight is important to you, what the cost of medications is, and all these things so that they can kind of take that all into account before figuring out which medication is right for you. So thanks everybody for tuning in today. I will hold here, and I think Dr. Edelman's going to give a presentation, and then we'll take questions from the audience at the end.
Thank you, Trish. If you can release your slides, I will put up my slides. That was an excellent presentation. It really was. And I think it set the stage for what I'm going to be talking about, which is taking everything you've said and actually put it to use in a practical way for patients that we see at the university and the VA. I should let everybody know that my presentation is 30 minutes, and then Dr. Pettis, Jeremy Pettis, has been scouring the Q&A section, and he's going to help throw the questions to us when we get done, followed by our health fair. I just want to let some of you know you're writing your questions in the chat box, which is great, but move them over to the Q&A section. Okay, Tricia, thank you for staying on time. I want to warn everybody that these presentations, they're not that simple. And I think the way we designed tonight was perfect because Tricia got you used to the SGLT-2 word, the GLP-1 word, and these cases, I didn't dummy them down, but I did take away some of the medical jargon that you may not be familiar with. So let's start. This is just an introductory slide. You can see this is 1990. This shows the number of people in the United States with type 2 diabetes in terms of percent. There are people that we don't even have, there are states we don't even have data on in 1990, like Alaska. And you can see only 4 states were red, which meant above 6% of the population had type 2 diabetes. Let's go to 2020. Look at that. That shows you that we have had a tremendous increase in the number of type 2 diabetes. And there's actually a darker red than the above 6%. It's above 10%. And believe it or not, there are 6,000 people or more diagnosed with type 2 diabetes every day. And think about the numbers around the world are even higher. And it's been estimated that in the year 2050, 1 out of 3 Americans are going to have type 2 diabetes. Now, one other treatment strategy that's important to talk about before we get into specific cases is that your therapy may change over time. We call this the natural progression of type 2 diabetes. And typically, as Tricia said, you get diagnosed, you get lifestyle modification, you get put on metformin. Then you might need some other oral medications, maybe in combination, maybe that Trilogy pill with all 3 are in one, and then maybe a GLP-1. Then as time goes on, your doctor may say, hey, I think you need a little bit of insulin. And then eventually they say you need not just a little bit of insulin, but long-acting insulin, fast-acting insulin. They may even put you on an insulin pump. And this natural progression of type 2 diabetes, what does that mean? It means that even if you do everything right, you follow your diet, you exercise, you take your medications as prescribed, your caregiver may need to add more medications over time. And that's something that people really have a tough time with because they just don't want to take a zillion medications. And this process may occur over time, 10 to 15 years, in fact. So that's an important concept. The other concept is that type 2 diabetes is a polypharmacy condition. What does that mean? It means if you have type 2, you're going to have not only diabetes, but probably other cardiovascular risk factors, such as high blood pressure, abnormal cholesterol, aspirin. You may have sleep apnea, you may have erectile dysfunction. And if you get treated with each one of these, for each of these issues, you will be on a lot of medications. So for example, you could be on 2 or 3 oral medications. For your diabetes, you could be on 1 or both injectables, basal insulin and these GLP-1s that Tricia outlined so well. You might have high blood pressure. Almost every patient I have with type 2 diabetes that has high blood pressure is on more than 1 blood pressure pill, typically 2 to 3. You may have abnormal cholesterol levels. Your HDL may be too low. Your LDL may be too high. If you're over 50, you probably should be on aspirin. Please talk to your doctor. And a CPAP machine. That's for people with sleep apnea. It happens to be very common in people with type 2 diabetes. And if you're a guy with erectile dysfunction, you may be on something like Cialis or Levitra or Viagra. So it's one of these type of things where if you have type 2, you need to expect that. I know I've heard from so many patients, do I really need to be on all these medications? And if you're not sure if you need every one of your medications, please have a discussion with your caregiver and just go down each one. Okay, ready for the first case. 32-year-old male. So you got to put on your doctor hats now. 32-year-old male with type 2 diabetes for 2 years. Medical history, obesity, high cholesterol levels, hypertension, and heart disease. He had a heart attack. Now, one thing you're going to see so commonly in all these presentations is patients have weight problems, and that's inherent to the condition of type 2 diabetes, high cholesterol, high blood pressure, and heart disease. In fact, I dictate my notes at UCSD, and one day I met the lady who dictates all my notes, and she really kind of gave me a little bit of grief. She said, how come all of your patients have, weight problems, cholesterol, blood pressure, and heart disease? And I said, that's because they do. She thought I was just copying and pasting what I dictated for other patients. It is so common. And for those of you with type 2, you can empathize with other folks with type 2 as well. Okay, family history, very strongly positive for people with type 2 diabetes, obesity, and heart disease. This person doesn't test their blood sugar very much at home, and I get it. No one likes to prick their finger, and it's one of the setbacks, because we as providers need that information. You as someone living with type 2, it's just difficult to do. And here's the medications. Ready for this? Metformin, glipizide, a DPP-4 inhibitor called Januvia, an SGLT-2 inhibitor called Jardiance. You've seen these on television probably, and basal insulin, Lantus. So this individual is on 5 different pills and basal insulin. Very importantly, let's take a look at his glucose control. Well, his most recent one was 11.4%, meaning that his average blood sugar is well over 250. 1 year ago, it was 10.6. And 2 years ago, when he was diagnosed, it was 10.1%. So that's the case. Now, for each of these cases, I try to bring up the most important information. Okay. He has a history of heart disease. He already had a heart attack. Super important information. Second, his diabetes control really is, I wouldn't even say bad, I'd say horrible. And the other thing that's part of his history that really stands out is that despite adding all these diabetes medications, his glucose not only did not improve, it actually got worse. So here's the question for all of you. What is the most likely reason why this person with type 2 diabetes has not achieved his A1C goal, which is less than 7%? Well, here's the answer, and the answer is correct because these are real cases. Poor adherence with his medication. He just was not taking his medication and did not tell his caregivers that he was not taking his medication. So his caregivers just kept adding on more and more medication and increased the dose of each one, and they're all just scratching their heads saying, I don't get it. How come he's not getting better? Now, this is a doctor slide, but I think you'll follow it with no problem. This is data from the National Health Survey for people with type 2 diabetes, and it shows the percent of people with type 2 diabetes who have achieved a hemoglobin A1C less than 7%. That's the goal. That means that your average blood sugar is about 155 on average for the past 2 to 3 months. Now, you can see the dates, 2003 up to 2018, that's 15 years. And it hasn't changed. In fact, it's gotten worse. Only 50% in the most recent data collection, and as high as 56% way back when we had all the older medications. No change in 10 years, despite the advancement of all these new medications that Tricia covered, the DPP-4s, the SGLT-2s, the GLP-1s, basal insulin, combination pills. So what is happening? It's quite striking, and most caregivers do not realize this. Let me show you some data that will knock your socks off. And I really should say, knock your virtual socks off. Okay, you ready for this? For every 100 prescriptions written, only 50 to 70 ever make it to the pharmacy. There may be things lost in translation. People don't drop off their prescriptions if they were given a handwritten one. 48 to 66% leave the pharmacy, hopefully to the right person who needs it. 25 to 30% are taken properly, and only 15 to 20% are refilled. So the bottom line is prescriptions are not always filled, taken properly, or refilled as directed. This is the single biggest problem in type 2 diabetes. And I know I'm relating to a lot of you folks with type 2 who may be in this category. So listen, living with type 2 diabetes is hard. I have type 1, but I realize that it is very hard if you have type 2. So, and I would say it's sometimes harder. It's difficult to take the medications regularly. I mean, especially if you're on a handful of medications. Cost is prohibitive. You do not feel different if you take your medications or not. There's not that sense of urgency. So you might say, screw it. Why should I take them if I don't feel any different if I take them or not? Side effects are scary, especially the ones on television. And sometimes you just feel like you're failing and you just lose your motivation. So I think communication is key with your healthcare provider. You know, it's really important that you have a good discussion with your healthcare provider, because if you're not honest, you know, he'll add another medication, she'll increase your dose, you know, they'll initiate or increase insulin. So, and that can lead to problems, because if you eventually take some of them, you might have a serious low blood sugar. I spend a lot of time on that because I do think it's quite important. Okay, case 2, 69-year-old overweight woman with type 2 diabetes for 10 years. This is how we kind of give the one-liner. You say the age of the patient, the sex of the patient, and very importantly, how long they've had type 2 diabetes. Because remember, I talked about the natural progression of type 2 diabetes, that over time, you might need more medication. Okay, medical history. Obesity, high cholesterol levels, high blood pressure, sleep apnea. Family history. Type 2 diabetes runs so strongly from generation to generation. Both parents and 2 siblings had type 2 diabetes. Recently admitted to the hospital for congestive heart failure. Big red light goes on for most doctors when a patient has congestive heart failure. That's a serious event. It means that your heart cannot pump strong enough to get the blood out of the heart to the rest of the body, and your lungs fill up with fluid because it just doesn't get enough heart pumping. And then you have problems breathing, you get ankle edema. Some of you that are viewing tonight probably had or have congestive heart failure. A1C, 8.5 to 9% for the past 5 years. And you can see some of the home glucose monitoring data. FBS means fasting blood sugar in the morning, about 147 to 219, and a few post-dinner blood sugars, 188 to as high as 275. Now, this individual's on 2 medications. They're both older, Metformin and glipizide. And let's just assume that case 2 to the end, the rest of the cases, people are being fairly adherent with their medication. And this person, like many people, they don't want to take injections. Okay, let's review the most important things about this case. I know I'm giving you a lot of data, but I want to give you a feel for how complicated these cases are as well. Recently admitted to the hospital for congestive heart failure, where they drain off fluid, give you diuretics. Sometimes they have to give you medication to help your heart pump a little stronger. Okay, this person also has very poor glycemic control. Remember, our goal is less than 7, at least less than 7.5. And this person is overweight, 240 pounds, and they're only 5 feet 4 inches tall. So weight is a huge issue with this patient, makes congestive heart failure worse, glucose levels worse, blood pressure, cholesterol levels difficult to control. Okay, how would you treat this patient to get her A1C down? And as you know, we have lots of choices these days. Well, for this particular patient, adding an SGLT-2 inhibitor, and I list them there because I want to make sure these names get ingrained in your brain. Farxiga, Jardiance, Invokana, Steglatro. These are the marketing names. Why this choice? As Tricia said, when you have kidney disease or you have heart disease that is specifically congestive heart failure, these drugs are extremely protective. So they protect against heart failure. They're taken once a day as a pill, very easy. They help with weight loss, which will help this patient, and they do not lead to low blood sugar. And that's another thing that Tricia stated about this class of agents. And I can tell you that there are as many cardiologists using these drugs as kidney doctors, because they know, especially for patients with congestive heart failure. So she did get put on one of the SGLT-2 inhibitors. You start off at a low dose, you go to the maximum dose. Her A1C dropped to 7.3%. She lost 15 pounds. And these are kind of typical drops that you'd expect. I'm not giving you the best case scenario or the worst case scenario. She did get a yeast infection That's one of the side effects of these drugs because, as Tricia mentioned, they're pushing sugar out into your urine and you could get a urinary tract infection. But you cannot buy these drugs back from the patients because they love the fact that they can lose weight. And when they start losing weight, start feeling better. This woman started walking more because she felt motivated. She was lighter. She felt stronger. And very importantly, she reduced her chances for having another episode of congestive heart failure. Okay, case 3. African-American woman with type 2 diabetes for 13 years. She's 62 years old. Very important history. You know, we know that African-Americans have a huge incidence of type 2 diabetes. So do Latinos, Native American Indians, and Pacific Islanders. Don't ask me why, but it's in the genes. And so it's really important that we address diabetes education, prevention in all of the ethnic groups hit very hard by type 2 diabetes. Okay, she is on maximum doses of 3 oral classes of medication: Metformin, glipizide, the 2 older medications, and she's on an SGLT-2 inhibitor already. Once again, Farxiga, Jardiance, Invokana, Steglatro. Don't you love these names? Both parents and 2 siblings have type 2 diabetes. And not only do they have diabetes, they already have early heart disease. So they've had a heart attack, they may have had a stroke, they may have had congestive heart failure. Once again, very typical history: high blood pressure, abnormal cholesterol, and weight problems. Now, she herself, she didn't have congestive heart failure. She had a myocardial infarction. And the S/P, that's doctor terminology. I thought I'd throw some in there for you. Status post cardiac stent insertion. What's a stent? A stent is like a stiff little straw they put in your arteries through a catheterization to keep them patent, to make the ability of the blood flow to go through, because certain areas of the cardiac vessels, they clog off. They develop atherosclerosis. So stents are life-saving devices. And some of you probably have already had stents. So she had a heart attack. And that's not a good sign, because myocardial infarction means part of your heart muscle died. And if you don't have all your heart muscle, guess what happens? You don't pump blood out very well, and you go into congestive heart failure. So it's a pretty serious condition along with congestive heart failure. And this woman adamantly did not want to take insulin. Many of her relatives took insulin, and she thought they did not do well on it. And one thing she was fearful of was gaining weight. And people with type 2 have a tendency to gain weight, and it's so difficult to get it off. I don't blame anybody that is really hesitant to do anything that's going to make them gain weight. So her A1C was 8.8%. We don't need to get this person's goal less than 7%. Less than 7.5 is a very good range. It means her average blood sugars are, around 160, 170 most of the time. And the other thing about her history that's important is that her morning blood sugars were too high, on average about 180 to 220. Okay, that's her medical history. What are the most important things about her medical history that I pulled out that helps me focus in on the best therapy? Okay, first one, big red lights going off. As Tricia mentioned, the first thing that I'm going to ask, does this woman have heart disease? And does she ever? She has a heart attack, and she's had to have 4 stents put in. Secondly, she also has a strong family history of heart disease. And that's important to note, because heart disease runs strongly from generation to generation, just like type 2 diabetes. And the more risk factors this woman has, or any patient, the more aggressive I want to be to treat heart disease and prevent it. And she also has poor glycemic control. So these are the areas that I'm going to focus on. So if you ask yourself, what would you recommend now for this patient? Now remember, she was on metformin, glipizide, and SGLT-2 inhibitor already. There's one class of medication that Tricia covered that is very good to protect your heart, and it is a GLP-1 receptor agonist. And those are listed here: Victoza, Trulicity, Bydureon, Ozempic, Rybelsus. And there's basically no other choice next for this woman based on her history. So we know that these GLP-1 drugs, they protect the heart against heart attacks and strokes. Remember, SGLT-2 inhibitors protect against congestive heart failure. They're all in the big category of heart disease. We know that we can inject these devices, these medications, daily, weekly, and now orally. They also help with weight loss, just like the SGLT2 drugs, and they do not cause hypoglycemia. So it's a very important class of medication. Let me say that the first one was approved by the FDA, believe it or not, in 2005. They've been on the market 15 years, and we know their safety track record, and they're extremely safe. And every medication that you've heard today on today's webinar has side effects, so that's something that you need to discuss with your caregiver. Okay, she agreed to start a once-weekly GLP-1 receptor agonist. They come with nifty pens that are easy to inject. Take a look at her average blood sugar in the beginning, before the GLP-1, about 200. Afterwards, her morning average fasting blood sugar, FPS, was 139. And occasionally, PPG means postprandial glucose. Try to get you guys up so that next time you watch a Marcus Welby show, you'll know what they're talking about. How about Dr. House? He's one of my heroes. After eating 167 on average, that's pretty darn good. So she experienced mild nausea. That's one of the commonest side effects with this class of drug. And it typically goes away. She did not develop any hypoglycemia. And over the next 3 months, she lost 13 pounds, and her A1C fell from 8.8% down to 7.2%. So this is a very typical response. I don't like when people show cases of people losing 50 pounds and the A1C going down to 5. That's not realistic. This is very typical. And it's important for you to discuss these medications that you think may help you with your caregiver. Okay, case 4, we're doing well. 55-year-old obese Latino male, another ethnic group hit hard by type 2 diabetes. Now, he's had type 2 diabetes for 22 years. Unfortunately, he's got chronic kidney disease. He does have coronary artery disease, which is either a heart attack and a stroke. He has high blood pressure, sleep apnea, super common. He's got arthritis and obesity. So his current treatments are Metformin, SGLT-2 inhibitor, and a GLP-1 receptor agonist. So he's already on Metformin and 2 drugs that protect his heart. So he's already been seeing some pretty good doctors. Oh yeah, me. Kidding. His A1C was 9.9%. Take a look at his blood sugars. Before breakfast, the average is about 212, of course, bouncing around a little bit. And the bedtime blood sugar average is about 184. Very important information. So what are the most important parts of his history? Very poor glycemic control, history of heart attack and stroke, but he's already on these protective meds. And you know what I'm going to do in addition to using these 2 drugs? I want to make sure his blood pressure is good, his cholesterol is good, he's on an aspirin if his cardiologist approves that. Don't forget that these drugs do protect the heart, but you can't forget the basics, and that's cholesterol levels and blood pressure. A lot of people sort of forget about those with the excitement of these new drugs that are protective. And very importantly, his morning blood sugars are elevated. We know that if you start off the day with a high blood sugar, you don't do very well the rest of the day. So what do you think we would do with this patient to bring down his morning blood sugar? Start him on basal insulin once a day. Very easy. And we'll talk about how you do that and titrate it in a second. There's a lot of good basal insulins out there. Lantus and Basaglar and Levemir are older ones. Toujeo and Tresiba are newer basal insulins. And that just comes down to a discussion with your caregiver. So they're very effective at bringing down the morning blood sugar. That's how they work. They bring down your morning blood sugar to a good range, and then people seem to do much better the rest of the day. They can cause low blood sugar and weight gain, but with this method, using basal insulin, starting with a low dose, titrating up slowly, these problems can be minimized. So insulin degludec was started in this gentleman, started off at 20 units, titrated up to 120 units. Now, I know some of you are gasping, oh my God, 120 units? That's not that atypical. Remember, the total dose of insulin is not the most important factor. It's what your blood sugar goes to. That's the most important. And if you look at his blood sugar readings, pre-breakfast has come down to 122, and even bedtime blood sugars down to 155. So his A1C dropped to 7.1. He did gain 2 to 3 pounds. That's not too bad considering the beneficial effects on his A1C. And he was taught to self-titrate 1 unit every day until his morning blood sugar got less than 140. Here's just an example of the titration sheet we use in clinic. We fill this out for the individual folks going on it. We give them the type of insulin they're on, let's just say Lantus. We tell them when to take it in the morning. A lot of times it doesn't matter, morning or night. Start with 20 units, and you can see here, every day, if the person's blood sugar is over 140, increase by 2 units. Below 90, subtract by 2 units. So that way, this patient slowly increases their dose until their morning blood sugars are at goal. It works extremely well. And that way you can do it on your own. You obviously need a glucose meter. Now, in some of my concluding slides, I want to really emphasize that continuous glucose monitorings are not for just us cool type 1s. It's being used in type 2 all the time, and there's more and more devices that's become available. I mentioned the Libre 2 and the Dexcom G6. They're both approved by Medicare. They're both, you don't have to prick your finger, and there's various differences and pros and cons with each one. It's up to you to really investigate them. But very importantly, you can get a blood sugar every 5 minutes and with alerts and alarms. Okay, this is an example of some of the downloads. This person downloaded and said, yeah, the 25% of this individual's numbers are below 70. You can really pick up that, hey, I didn't realize I was having that many low blood sugars. This individual down here, you can really see on how these software programs analyze these blood sugars. Remember, 288 measurements a day if you look at every 5 minutes. And you can see that, hey, what's the biggest problem with this person? Popping up after breakfast. You know, those Pop-Tarts with the brown sugar topping just will do that to you every time. This is the last case, and it's a very quick one. This is the data you have. 68-year-old male, he's on a bunch of oral medications. He's on basal insulin. You can see that his morning blood sugars are pretty darn good. This level here you can see is about 150. But what's the main problem? You can see the arrow. This guy pops up after dinner. So you can try non-pharmacologic approach like spreading the calories, eating less carbs, eating less, and exercising after dinner. If that doesn't work and you're still popping up after dinner, this is the one area to focus on. And so you can add a fast-acting insulin in that case. And don't forget, insulin pumps are not only for type 1s. Insulet makes the Omnipod Dash and an insulin management system for type 2 diabetes. This is a gentleman that we wrote an article about in our TCOID newsletter. You can see the little device on his arm, and he controls the pump with a handheld device. So remember, if you're type 2 and you're on basal and fast-acting insulin, instead of giving yourself a zillion injections, you might do really well on an insulin pump. So before I give you my last announcement, I think this is a great slide. And I have an Edelman report video on this. Get type 2 diabetes, control it, and live life and live longer because of it. And I've learned that from my good friend and colleague, Bill Polonsky, that you know, it's a godsend for when some of you folks come down with type 2, because instead of just not realizing your blood pressure is high, your cholesterol is high, your diabetes is out of control, that all of a sudden you get diabetes, you realize you have all these abnormalities, you start controlling the problems, and you live a much healthier life. I want to make sure everyone marks their calendar for August 1st. That's our first full day virtual TCOID conference that is taking the place of our Saturday programs. We call it Omaha Without Borders because it was supposed to be in Omaha, but now we're opening up basically throughout the universe. And the Making the Connection program on the right is for healthcare providers. Now, after the Q&A section, after Trish and I finished, right at 5:30 or 5:25, you've been sent some links in the confirming email. And also Michelle Day, who's monitoring our chat room, will put the links in there as well. And Alex Boris from Dexcom will be there to answer questions about the Dexcom G6. Shore Salter will be talking about the Insulin Omnipod that I just showed a picture of. Cami Di Roberto works with Xeris, and their company makes an emergency glucagon kit, a brand new device that it works like an EpiPen. So it's really easy to give yourself glucagon in an emergency situation or near emergency. And then Eric Fox with Tandem, who makes an insulin pump that is also used for people with type 2 diabetes. Okay, so now Jeremy Pettis, who is a very close friend and trainee with Tricia. They did their residency together. They did their fellowship together. They're on faculty together. They're a work couple, and I've never seen them get in an argument, never had to send them to therapy. And it's been a pleasure to work with them all of these years. So Jeremy, we are ready for your questions.
Yeah, well, first of all, congrats, guys. I think you guys did a really good job. And the Q&A, there's been a ton of questions I've been doing my best to try to answer, but a couple I wanted to do live. So in no particular order, one of the questions I'm paraphrasing is that we talked a lot about medications, insulin, et cetera. What about things that are kind of non-medication based, and specifically gastric bypass surgery came up? So I don't know if you guys want to talk about that and when you might consider that or how you would kind of fit that into the algorithm.
Trish, let's take turn going first. Would you like to do that one?
Sure. So first of all, I would say that, bariatric surgery or there's several different types of weight loss surgeries that are available now. So if this is something that you're interested in, I would definitely recommend going to a center that specializes in this, because there's kind of the traditional gastric bypass surgery, there's gastric sleeves and gastric banding and all sorts of new and fancy procedures that are available. So it's kind of like all these medications, there may be a surgery that's better for a certain person and one surgery that's better for someone else. So there's not kind of a one-stop shop there. There is a lot of data that shows improvement in blood glucose and in diabetes in patients after these kind of gastric bypass surgeries. Some of them are kind of stronger at improving diabetes than others. So the actual gastric bypass and the gastric sleeve, because they change some hormonal things and anatomy that's going on, can actually be more effective at helping the diabetes. There's also, when diabetes improves after gastric bypass, we say that it goes into remission, which kind of sounds like cancer going into remission or something. But the reason we say that is because it can come back. And that's because once you have those genes for type 2 diabetes, you will always have them. So it may improve significantly. It may, quote unquote, go away forever, but it also can come back with weight gain. And some people who have had type 2 diabetes for many, many years, it's harder for the diabetes to go away after gastric bypass surgery. And that's a little bit hard to predict, but now there's even some scoring that they're doing where they're trying to be able to predict, what the likelihood of whether or not your diabetes will go away after gastric bypass. But it certainly is an option. There's a lot of things that we didn't talk about today, including lifestyle and exercise and nutrition. And unfortunately, we can't cover all of that in an hour. But that is there is a lot more information on that on the website, and gastric bypass is one of those other options.
Yeah, thanks, Tricia. I'm not going to really, you said it all pretty much, but gastric bypass, is a serious operation. They do have other like gastric banding and all kinds of bariatric devices, but I think it's just important for you to learn as much as you can about them. And typically people who go for gastric bypass are 100 pounds over their ideal body weight. And I've had patients who has changed their life for the better, never going back. And I've had others who gain the weight after they lose 100 pounds. So you can't just have the surgery and think you're fixed. You have to do all the other things with it, emotional help, change your habits. So it's definitely an important question. So thank you for asking that.
Okay, so next, Chef Robert had a couple of questions kind of on the technology side. So two-parter. So one, any experience with the N-pen for type 2 diabetes? Maybe you guys can explain what that is, you know, how to maybe use that. And then he was asking about when the Libre 2 will be released. So maybe just a broader question about CGM in general and type 2s. So kind of a technology question for type 2s in general.
Yeah, I can start off and I'll let Trish add on. I want to make my answers brief because I know we have a lot of questions. But first of all, the N-pen. The N-pen is made by a really good company called Companion Medical, and it was designed to help people who are on multiple daily injections, not on an insulin pump, keep track of their insulin, to input information that may help them with dosing, to also bring in information from a continuous glucose monitor, the Dexcom G6, so that when you download the information for yourself, primarily and your caregiver, it gives you a very nice summary of how much insulin you used, when you used it, your correction factor, your insulin to carb ratio, when you gave it in relation to the glucose values, which is invaluable information to try to figure out what's going on. And you could use it with several different types of insulin. So I think it's really nice for people that are not on an insulin pump that want to keep closer tabs on their insulin usage in relation to their glucose values. The Libre 2, our newsletter came out just today, and there's an article on the Libre 2 that yours truly wrote, and the Libre 2 is going to be available in the next couple weeks. I've already called in a prescription for one of my patients with type 2 diabetes. The big difference between the Libre 2 and the Libre 1, the Libre 2 will give you an alert sound if you reach your upper limit or your lower limit. Whereas before, it didn't give you that alert. And you can customize those alerts. You can read about it online. Tricia?
No, the only thing I'll add on is I did see a lot of people asking questions about, the Libre is a type of continuous glucose monitor. So it's something that you wear on your body for 2 weeks at a time. The Dexcom is the other one our patients use commonly. And a lot of patients who are type 2 ask about coverage of these devices, because in the type 1 population, it's fairly quote unquote easy for us to get them covered. In type 2s, it really depends on the type of insurance that you have. So many commercial insurances will cover these devices for patients with type 2. And I would say for those of you that aren't that familiar with continuous glucose monitors or CGMs, there's a ton of information on the TCOAD website about them, and you can learn more about it. But essentially, it's monitoring your blood sugars without finger sticks, without pricking your finger anymore. And that's one of the things that people love. And it allows you to kind of see where your blood sugar has been going throughout the day and how food and activity kind of affects it. For Medicare, I don't have a good answer for those of you that are looking on ways to get continuous glucose monitors without being on insulin. Medicare, unfortunately, is not yet covering it unless you are on multiple injections a day of insulin. Dr. Edelman, I don't know if you have any secrets as to how to get that covered.
Well, with Medicare, there's no secret. You're right. I do know that depending on your insurance, and if your caregiver pushes for you, that you have a history of hypo-unawareness, that you do take insulin here and there, you might be able to get it covered. I know a lot of patients that pay out of pocket, and some patients use it on an interim basis. They might use it for a couple months, get things squared away, and then go off it for a while. But I do think that there are several companies, including Dexcom, including Abbott, that makes the Libre. They're trying to reduce the cost as much as they can, and the future renditions are supposed to be more affordable.
Okay, so this next one is from Samantha G. And I like this because it's just kind of a good overall basic question that maybe we probably all want the answer to. But it says, for busy folks who don't cook often, what would you all recommend as fast food, or is this just a no-go?
I got it. You go first.
Okay, so, unfortunately, it's the way the world works is that the food that is quickest to make and the food that is cheapest to buy is the most junk food, right? So you can go to McDonald's and get a whole hamburger for probably less than $2. And, same thing at the grocery store. Some of the really, wonderful fruits are more expensive than buying top ramen. So that's a challenge. But I would say, look at the menus and get used to looking at the nutrition info at all of the restaurants that you go to or fast food. There are really decent options that have, fairly low carbs or fairly low calorie. Even getting a small thing of like chicken nuggets at McDonald's is, calorie wise and carbs wise is not the worst thing in the world. I am not condoning that you should eat that all the time. But what I'm saying is there are options, and don't be afraid to customize. Like, you can go here in California, we have In-N-Out Burger, and they have ways that you can order your hamburger without a bun, and you can order it wrapped in lettuce. And don't be afraid to kind of customize if you're going through a drive-through. If you're looking for quick options at home because you don't cook, then a lot of the frozen foods now, and there's some really healthy organic options if you're interested in them, but like Lean Cuisine and Annie's and all of these kind of pre-packaged meals, you throw them in the microwave for 3 minutes. They're very easy, and they're portion control for you. And so those are really good options for people that are not interested in cooking.
Yeah, thanks, Tricia. We all have our own favorites, and what I try to do is just get food that's lower in carbs. And if things are lower in carbs, they're probably lower in calories. You mentioned the In-N-Out Burger in the lettuce, and that's really good. There's a pizza place in San Diego called Lucadia. They have cauliflower crust pizza, and a lot of places are doing that. So the carbs are 1/5 of a regular pizza. Sometimes I'll just go to the burger lounge and get a veggie burger, but here's the key, is not to order the French fries or the onion rings. And that's a killer. And I also can pick up from an Italian place or a pizza place, individual meatballs. So it's a lot of protein and it doesn't raise your blood sugar. Now, I've learned what Jeremy does. He goes to a place, gets a huge sandwich or a big cheeseburger with bacon, cheese. He cuts it in half, and he only eats half at a time. And, he saves the other half for later. So, you're spreading your calories out. So that's, it's a great question. And Pollo Loco, it's just roasted chicken. I think Kentucky Fried Chicken, now you can get it roasted, not breaded. So I think, Tricia, you made some good suggestions. Just look at the food labels. In California, they have to list the nutrition contents of the food. And then we'll have to get Chef Robert, who's on the webinar tonight, to maybe write us an article on the best fast foods for people with diabetes, type 1 and type 2.
I'm just laughing to myself listening to you guys. I realized I went to Chick-fil-A today, and you can get 8 grilled chicken nuggets, 140 calories. So that's a good option. And then yesterday I had my protein style double at In-N-Out. So I got to hop on the bike or something today. But anyways, next question. It says, I have been hearing Metformin has been having recalls. Is that true? What's going on with that?
Yeah. Trish, go ahead.
So there have been some recalls with some of the Metformin formulations. Most of them are in the extended release Metformin, not the immediate release. And the vast majority of people are taking immediate release, which means you take it twice a day because it's a shorter acting. The recall comes because they found a small amount of a material that's in the Metformin that can be dangerous to the body. It's a very, very tiny amount, and they're not actually sure that it does cause any harm, but they're being extra cautious in recalling it. So if you're taking Metformin, you can have your healthcare provider kind of double check. It depends. You can look up the type of metformin that you're on to see if it's actually been recalled, and then double check with your healthcare provider.
Yeah, I just add, no one should be freaking out, but if you have the extended release, if you're in a big institution or like you get your meds from, CVS, they'll screen for you. They'll let you know, they'll substitute it. So I think I agree with you, Tricia. I don't think it's a huge risk, and they don't even know yet. So no one should really panic.
Okay. So we had a couple of questions along the theme of morning blood sugars going up for no reason. Waking up with a quote unquote good blood sugar and it goes up for, without eating. What's that about?
Yeah, I can take that first, Tricia. Well, basically that's extremely common. It's very common to wake up in the morning, you check your blood sugar, it looks pretty good, like 120. You go to the lab and you're fasting. You haven't eaten a darn thing. You had water. And then your doctor says, oh, you were 220. It turns out that the act of waking up raises hormones in your body that are what we call counter-regulatory hormones. They're hormones that work against insulin. So we have epinephrine, we have glucagon. There's several. And when you wake up, it's kind of like, I don't want to call it the fight or flight syndrome. Maybe sometimes when you wake up, it's like that, especially if you have kids running around the house. But if you slept in, you probably wouldn't get that rise. And so for people with type 1, they have to sometimes take a little extra insulin, even if they're not eating. For people with type 2, if you're not on insulin, it'll go up, but you may not even know it half the time. So, and then there's this whole other thing called the dawn phenomena, where some people, it's the same sort of physiology, but your body produces glucose in the early morning, and it's not unusual to go up overnight. And there's ways to treat that. Basal insulin at night is something that one of our cases had. And so it's one of those very frustrating facts. Tricia, do you have anything to add to that?
No, the only thing I'll add is that because of those hormones, this happens in everybody, whether you have diabetes or not. But because of those hormones, your body is more resistant to insulin in the morning. So things that normally may not cause your blood sugar to rise as much later in the day, it just goes crazy in the morning. So your insulin, if you're on insulin, it may not work as well in the morning. And a lot of my patients have their blood sugars rise a ton with coffee in the morning too. Coffee without sugar, without cream, will make your blood sugar go up a little bit in the morning. And some people need to take a little extra dose of insulin if they're on insulin for that.
Yeah, for people without diabetes like yourself, your pancreas just secretes more insulin and your blood sugars are normal. And for other people, they don't have that. So yeah, it's very common. And I just say sleep in all day. You shouldn't have any issues.
All right. Next question also is kind of themes that have come up around taking GLP-1 medications like Victoza, Trulicity, Ozempic, and people liking the results in terms of blood sugar and weight, but just one of the GI side effects is really been prominent, that they've had a lot of nausea, they've had GERD, indigestion. They don't want to stop the medication. How can they kind of get through it, or do they have to come off of it?
Yeah, I would say, so those GLP-1 medicines that we talked about, the ones that work just like your gut hormone and that protect your heart, cause weight loss, the most common side effect by far is GI symptoms, usually nausea, a little bit of nausea. So most of them, the way we get around that is we kind of start with a very low dose of the medication. And sometimes the medication will say that you should increase the dose after 2 weeks, or it just depends on which one you're on. Oftentimes, I just check in with my patients. And if they're having a little bit of nausea, if we leave them on the lower dose for longer, your body kind of gets used to it. So that's one way to get around it, is to stay on that lower dose for longer. Some people, were doing fine and then they went on a higher dose. You can come down to a lower dose if you need to. Oftentimes after your body kind of gets used to it, the nausea will go away. And it's really kind of a balance between if you're really super miserable and how much you like the effects of the medication. Because I have some patients that are nauseous that say, but I love the weight loss and I love what it's doing and I'm willing to kind of stick it out. And then the nausea can kind of subside a little bit.
Yeah, Tricia, you said it all. I'll just emphasize it's very slow titration, and eventually your body should get used to it. But every once in a while, all of us caregivers, healthcare providers, we get patients who are just, no matter what dose you use, they get severe nausea. But I'd say the vast majority do really well if you start low and go slow. And I've had patients titrate to like level 3 and they say, well, this is really bad. You go back to the prior level for a little while, and most people get used to it. And I want to sort of let everyone know that those medications are worth going through the hassle of getting used to it, because they're so beneficial on so many levels.
Okay. So kind of back and forth, but let's do this. So the next question, maybe we can do this one quickly, but it says, I've been, not because it's a bad question, but just specific. It says, I've been recently diagnosed. My question is, if I take insulin now, will it help my pancreas with a little jump start to work better, or will it hurt and make my pancreas even less effective?
Well, I'm assuming you are a type 2, and for sure it won't hurt, but it will do nothing to help prevent future issues. Right now, the best things you could do is get on some of the physiologic medications that Tricia spoke about that will allow your blood sugars to be under good control, with the other benefits of protecting your heart, reducing the risk for hypo and weight loss. So I would say you're one of the few patients that want to go on insulin when you're first diagnosed. You're crazy, man. No, it won't hurt you, but I don't think it's necessary. And then you're at risk for low blood sugar and weight gain.
And I would say the only time when insulin is, I agree, it won't hurt, and sure, it can help in terms of your blood sugars, but not in terms of kind of preserving your pancreas. One time when insulin is very important is if your blood sugars are so high, like they're in the 400s and 500s all day. You can be on as many pills as you want, but something happens in the body. We call it glucose toxicity. It's kind of a big term for a lot of things going on, but it means that the pills don't work. They just don't work when your blood sugar gets that high. So sometimes we have to start insulin just to help everything kind of calm down so the pills can work again. So that's one circumstance where it may be really helpful. But again, it's not kind of preserving your pancreas for the long term.
Yeah, like you said you were just a patient, or the question came in, someone newly diagnosed. A lot of times they're just exactly what Tricia described. They didn't really know they had type. They show up to the emergency room, blood sugar's 300, and I love that phrase, glucose toxicity. And sometimes you're right, Tricia, you got to treat them with insulin just for a couple weeks to get their blood sugars down, and then they respond very well to oral medications and also the injectable agents. There's a lot of good insulin out there. Every animal on this planet is on insulin from their own pancreas. So it's a natural hormone, and it's really important part of our whole armamentarium to treat people. And as Tricia said, everybody's different. I love those pictures in your slide deck, Trish. I don't know where you get them, probably from your kids. From Gigi, her drawings.
All right, guys. A general CGM question. What about issues with adhesive, it falling off too early, or maybe even being itchy or whatever? How do you help people get their CGM to stay on and to not bother them?
Your turn, Trish.
Well, there's a lot of different things out there. I would say, first off, the CGMs, the companies will tell you that they're only approved to wear on your stomach, or the Libre will say they're only approved to wear on your arm. And it turns out that's just because that's where all the studies were done, and you can try them in different places, because some people may, sweat more in a certain place, or just make it, hit their belt line or something. So I would say move it around, try different areas to see if it stays on. There are certain things that can help it stay on better. So there's things like something called Skin Tac, SKINTAC. And it looks like a little alcohol wipe, and you can rub it on before you put your CGM on, and it will just help it stick better. You have to let it dry before you put the CGM on. That's one thing that people don't do sometimes, and that will help. There's a lot of companies that are making little kind of tapes and things that actually have a hole cut out for the CGM in it that fit really nicely. Griff Grips is one that you can get on Amazon. There's some that we can order as doctors for you, like Tegaderm. So we can actually put a prescription in, because some of these things can actually get quite expensive to pay for out of pocket. I don't know, Steve, if you have other suggestions.
You know what, those were all the ones I was going to say. A lot of times I will put the person with diabetes in touch with a representative from the company, and they have lots of suggestions, maybe not to where to put it, but because they deal with problems with irritation and falling off, and nothing worse than a expensive sensor falling off your skin. So
Yeah.
I like the Griff Grips, GRIF, they seem to be like stretchy, like textured tape that really sticks pretty well. You can get different colors too. I like turquoise blue myself.
The other one thing I'll say is for people that have a like a hypersensitivity reaction on your skin, one thing I found that works well is so steroid medicines can help reduce like a hyperreaction to your skin. But if you try rubbing like hydrocortisone cream or something on your skin, then sometimes the sensor doesn't stick on that well. So something that we've found works well is you take the nasal spray, it's an allergy spray that has steroid in it, like Flonase or Nasacort. They're over the counter now. You don't need a prescription. And you can literally just spray it on the area that you're putting your CGM on. Again, you let it dry before you put it on, and then put the sensor on top of that.
You know, that's a great suggestion, because it's really heartbreaking when someone really needs to wear a CGM and they can't do it because they get skin allergies. Thank you for that.
All right, guys, I think you should wrap it up with something catchy and cute, and take it home for us.
Boy, nothing like pressure. Well, I don't know how catchy or cute this is, but I want to thank you, Tricia, for giving such a great presentation. It's been an honor and a privilege to work with you all of these years. And you know, you really have a special talent of speaking to people with diabetes, students, and healthcare professionals. And it's been fun tonight, and taking time on your vacation to educate all of us on the webinar tonight. And Jeremy, thank you so much. Thank you for sharing with us that all the fast food places you've been to in the last 24 hours. I love it. And I didn't realize Chick-fil-A had the little chicken things without being breaded. That's awesome. Okay, there's one by my house. Okay, remember everybody, we got the health fair links that should be in the chat box, as well as in your confirmatory email. Check out our website for future webinars and other information, and put August 1st in your calendar. So with that, I think we sign off. Sarah, you want to cut us off? Sarah is our moderator tonight behind the scenes. Tricia, you have a good vacation, okay? Okay, everybody. I'm gonna end it.